Hello, doctor. My name is Dr. Sanjoy and today I am with a new case from my hospital OPD. A 32 years old man, actually he is a office job holder with sedentary lifestyle, having just a palpitation for last few days. Physical examination reveals that he is a good muscular person and he do a regular physical exercise and just having palpitation over the last few days, and on examination there is a definitive murmur. At this point I am not revealing the character, the site, the radiation of murmur, etc. You will imagine, or you will can gauge what type of murmur with this ECG. With my clinical finding of definitive murmur, I advise ECG, chest X-ray and echocardiography. This is the ECG. Please, you can pause the video for 30 seconds and find out the details of that ECG, please. Hope you can identify the finding. A few good findings are here. At first, there is left axis deviation, because we know left axis deviation we can find very easily the left lead, that means a lead 1 and lead 3 goes on the opposite direction. Lead 1, the R, positive deflection, and lead 3, negative deflection is more than positive deflection. That means left leaves in case of left axis deviation. Number 1. Number 2, there is definitive features of left ventricular hypertrophy. Left ventricular hypertrophy, as the short formula, it is SV1 plus R in V6 more than 35. So in this ECG there is more than 35 in V6 R and V1 DFH. This is the number 2 finding. And number 3, there is a strain pattern. This also goes in favor of hypertrophy of heart muscle. A strain pattern means ST, look at the V5 or V6, V4, most importantly V5, look at the V5. ST diffraction with T-wave inversion. ST diffraction, T-wave inversion. This is the classical feature of a strain pattern. What does the strain pattern signify? It signifies the cardiac ischemia actually. So left axis deviation with feature of left ventricular hypertrophy with a strain pattern, and a strain pattern most importantly in the lateral leads, that is V1, standard lead 1, AVL 4, 5, 6. So these are the features of this ECG. So you can conclude the ECG diagnosis having the patient with murmur. Next, this is the definitive investigation, echocardiography. It is actually 2D echocardiography, and the cardiologist definitely mentioned the diagnosis is HOCM, hypertrophic obstructive cardiomyopathy, and here is velocity, PPG, etc. And that's most important sign on echo, that is systolic anterior motion of AML, anterior mitral leaflet. It is the cardinal feature of HOCM, and that is associated mild systolic mitral regurgitation with dilated LA. In case of left ventricular hypertrophy, end diastolic volume of left ventricle raised that result in functional mitral regurgitation, and that is associated with dilated left atrium. And there is no regional wall motion, although on the ECG there is a stain pattern, but there is no definitive sign of ischemia. Good left ventricular systolic function with ejection fraction 68, and so on. So this is a case of HOCM. Actually, on physical examination, there is murmur on the left lateral border of the sternum and also over the aortic area, and it is actually ejection systolic murmur. Most importantly, murmur having no radiation over the carotid. So these are the clinical feature of murmur of HOCM, and this is the ECG, classical ECG, and it is the classical finding on echo. Thanks, big hand to our cardiologist. Okay, now some points on murmur found in case of HOCM. I already mentioned it is a systolic ejection murmur, crescendo and decrescendo type. That means whenever you find the murmur increase and then decrease, increase and then decrease, and it is of course systolic ejection type. And best head over the left lower sternal border. Actually, I found the murmur over the left upper sternal border, and sometimes audible at the aortic area. It is taken from the textbook actually, but really on the real physical exam, I found the murmur over the left upper sternal border and over the aortic area. And most importantly, I also mentioned that there is no radiation to the carotid. Whenever I found the murmur over that aortic area, I think this might be aortic stenosis, and I intentionally go over the carotid, but there is no murmur. I ask the patient hold the breath and repeatedly auscultate over the carotid, both carotid, one by one, but there is no radiation. So I thought that this might be case of HOCM. Okay, and this no radiation help distinguish it from the aortic stenosis. In case of aortic stenosis, the murmur classically radiate through the carotids. So it's very clinical pearl that uh, murmur of aortic stenosis versus murmur of HOCM. In case of aortic stenosis, murmur radiates to the carotids. In case of HOCM, murmur does not radiate to the carotid. But both are ejection systolic type. The question is why no radiation? In case of HOCM, the murmur is due to a dynamic left ventricular outflow tract obstruction, and it is caused by septal hypertrophy. The septal part of the interventricular septum being hypertrophy, whenever the ventricle contract, it is bulge. The septal part of the septum become bulge, and it make a functional obstruction in the outflow tract with a systolic anterior motion of the mitral valve, and there is no fixed valve narrowing. Actually, the valve is not narrow, but the subvalvular area, in the subvalvular area, a functional obstruction being created by bulging of hypertrophied septum during ventricular contraction. So it does not transmit sound efficiently up to the neck vessel. The murmur increases with some maneuver that decrease preload. In case of HOCM, we can take help from some maneuver that can increase the murmur or decrease the murmur. So we can increase the murmur with the maneuver that decrease preload, like standing from the squatting. I of course ask the patient from his sitting position to standing, and I keep auscultating his chest, and I found that the intensity of murmur goes up than before. On the other hand, the murmur decreases with some maneuver that increase free load, like squatting or hand grip. On the sitting position, if you ask the patient make his or her hand grip, you will find that the murmur goes down, murmur intensity become decrease, as because the preload is more. So in case of high preload, the ejection of blood from the ventricle into the systolic circulation will be less. So less blood ejection means less turbulence. So less turbulence means less intensity of murmur. So two maneuver we can take in case of HOCM. Usually we examine the patient on sitting or lying position, supine position. So after completion of examination on sitting position, at first ask the patient to grip his or her hand strongly and try to identify the intensity of the murmur, and then ask the patient stand up and again auscultate the chest and try to find out the intensity of the murmur. Is it higher or lower than the previous one? So this is all about my clinical case, my actual case of HOCM. Please share your experience of HOCM, put your valuable comment or experience, inquiry on the comment box. Thank you very much.